Everyone. On the behalf of Team CPC, I would like to welcome all of you in 7 CPC, which is going to be organized by or presented by the Gynae and Ops department. Life and time are the world's best teacher. Life teaches us to make good use of the time, and the time teaches us the use of value of the life. So now, without delay, I would like to welcome our dignitaries to grace the dais. Sir, his principal sir will join soon. So I would like to welcome CPC Convener Dr. Puneet Saxena sir, CPC Co-Convener and Additional Principal of Academy Dr. Monica Jain ma'am, and HOD of Gynae and Ops Department Dr. Pushpa Nagar ma'am. Welcome to all of you. In October 1889, Howard Edward Kelly was appointed as the first professor of Gynae and Ops department, and in university started as the establishing the gynecological department as the surgical specialty. So now to start the CPC, I would call upon Dr. Madhulata to take over to proceed the CPC. Dr. Madhu.
Thank you, ma'am. It's a privilege to welcome you all on behalf of the CPC team, and a very good afternoon to all the dignitaries on the dais, off the dais, respected seniors, my dear colleagues and juniors. You know, the grand success of this prestigious CPC is marked by the 7th CPC in the series, now being organized by the Department of Obstetrics and Gynaecology. So without any further delay, I would like to invite the backbone of organizing this CPC, Dr. Puneet Saxena sir, who is the convener, to address and give a SOP of the program.
Good afternoon, everybody. I welcome you all. And since Principal Sir is busy in Cath Lab and he'll be joining soon, so in the meantime, we'll start the proceedings. And I can see the senior faculty members of our college. I welcome them especially to the CPC. Thanks, madam. And this is the 7th CPC in this series, and we have seen very interesting cases in past, and I hope that today's case will also be very important, and it will put insight into the minds of the faculty and the residents especially. So we are doing this exercise every third Thursday of the month, barring a few exceptions when it's in holiday, and the presenting department, they present their progress basically about the structure and the function of the department and what are the new things coming, and then they discuss the case, which normally is a multi-specialty case. What I would like to request is that since the presenting department presents so much labor into it, we will like to have a better attendance. We are such a big college, and this is being an important academic exercise. So I will request that each one of us should propel others, especially the junior faculty and the residents, to come and attend this program. Also, we like that we see that there are cross references in the CPC, which should be taken up by the senior faculty members and not by the senior residents and the junior faculty. So it adds value basically, because this case is not only discussed here, but is put on the website of the college, and it's being dissected by other people also from outside the institute, and it's important for image of our institute that the case remains false. So that is important, and we are not short of academic material. So we are flush with the academic material, and we can select. And it's not only the owners of the head of the department, but all the faculty members to search and select and keep the data of such important cases so that we can present them in this CPC. So with that, I will hand over here and will request if somebody is there from ENT department, please note that the next CPC would be done by ENT department on 18th of April. That is the third Thursday of the coming month. And in advance, I wish happy Holi to all of you. And we will probably have a colorful CPC today. Thank you.
Thank you, sir, for the SOP. Now, you all know that OBG is a huge department spread across from Sanganer to Chandpur. And now Madam will, I don't know how she's going to justify the huge department. So I welcome Dr. Pushpa Nagar, ma'am, head of the Department of Obstetrics and Gynaecology, to give a bird's eye view of the achievements of the department.
Principal sir is arriving soon, and I will address him also, respected Principal Dr. Rajeev Bagarhatta, a thorough academician, Dr. Puneet Saxena, dedicated convener, and additional Principal Dr. Monica Jain, a vibrant personality. Our esteemed patrons, teachers of the Obs and Gynae department, Dr. Shashi Gupta ma'am, Dr. Veena Acharya, Dr. Neelam Bhardwaj, Dr. Vimla Jain, Dr. Krishnapriya Banerjee, and Dr. Leela Vyas. And august gathering of reputed doctors and students of the very prestigious medical college. Very good afternoon to all of you. Today I am feeling very much honored and delighted to introduce you to the legacy of Obs and Gynae department of this college. As we all know that Obs and Gynae department. Good afternoon, sir. Welcome, sir. As all of you know that the Obs and Gynae department, more than 90% we are females. And they have, despite so many of obligations, responsibilities, and the health issues, they are performing their duties very sincerely and very honestly without giving any botheration to the head of the department. So big clapping for them. The highlights of the department. Probably it is the largest department in the Asia, and I don't know, it may be in the world. And in 1868, the Obs and Gynae department was started in Mahila Chikitsalaya, and at that time it was known as Mayo College. How this department evolved. In first of all, in the year the Janana Hospital was started in 31, and in 52 it was affiliated to the SMS Medical College, and the Mahila Chikitsalaya was added to the department after being used as trial court in the meantime. And later on in 2009, the IVF center was established at Charak Bhavan, and which was later shifted to the Mahila Chikitsalaya in 21. In 2010, the department started in Pandit Deen Dayal Upadhyay Hospital, and again it was extended to the department, to the Kamartia Hospital, and to this Lakshya certification, a very important award the Janana Hospital received in year 2022. And in 23, the Department of Reproductive Medicine started. We are working at so many places. 6 units in the Janana Hospital, Chandpur, 7 units in the Mahila Chikitsalaya, 3 units in Pandit Deen Dayal Upadhyay Hospital, and 1 unit in Haribaksh Kamartia Hospital. We are giving our services to the City Colony Satellite Hospital also. To start with, when the department started in 1951, in OPD, the patients were very few, and the deliveries conducted were only 4,000. But at this time, the number of deliveries are about 60,000 per year, and the number of the surgeries are about 80,000 per year. So huge productivity of the department is, we can see. This artificial reproductive technique. This department was, the establishment of ART center was not an easy task. It was full of the hurdles and required a lot of sweat and efforts. And the doctors, our seniors, our patrons, during that time, they have put the very hard efforts to establish this department, and it was a milestone in the Obs and Gynae department, and it was all possible because of our principal, Dr. Ashok Pangadia, Madam Adarsh Bhargav. They have given so much hard work to this establishment of this department. Initially, when this department started, the OPD was only 600, and it has increased and to 13,000, and the success rate of these cycles were only 22%, and presently we are having the success rate of 66%, and which is at par the any excellent center of IVF, and that is a very remarkable achievement. RAJCare Advanced IVF Center. The facilities which should be available in any of the excellent center, whether it is GIFT, TISA, PISA, whatever it is, we are offering all the services to the couples. So this is a very proud thing. Lakshya, the certificate of appreciation. I am very delighted to share this thing that what is Lakshya? Lakshya is a program that is governed by the central government Ministry of Health and Medical and Health, and this is equivalent to the NABH, which is given to the general hospital, and this is for the improvement of the labor room and the operation theatre. And this award is equivalent to NABH, and this Janana Hospital was the first hospital attached to the medical college received this award. We are having the services, excellent services, which is according to the standard of global standards, the labor tables, all fully equipped labor rooms, operation theaters. We have all the gadgets, all the equipments, fully air conditioned, everything for the monitoring of the patient and the fetal monitoring we have. This is operation theater complex. This is our OPD. Then ICU and high dependency unit. Regarding the academics, the papers published in index journals, about 217 in year 20 and 21. The postgraduates and our teachers, all the faculties, they regularly participate and win prizes in various state and national level conferences. Recently, a resident of our department received a very prestigious award, Mrs. Indumati Jhaveri Award, AICOG Conference 2024. She was Dr. Swathi. In our department, we are conducting various training programs. The training programs we have conducted, the emergency obstetric services, the basic emergency obstetric services, the PPIUCD trainings, the comprehensive abortion care, and this preventive oncology, the implant training, we are conducting so many things. Comprehensive abortion care. In spite, as we know that in spite of the liberalization of the law of MTP, there is increased death. Almost about 8 to 10% of the maternal death are because of this unsafe abortion. So our aim is to conduct the program very seriously and to give the training to our doctors. They are working at the periphery so as to reduce the maternal death. This CAC training, what are the milestones? It was involved as an expert in framing Government of India's CAC service and training guidelines. Our department awarded first prize at national level as Best CAC Training Center. It was recognized as Model CAC Training Center by the Government of India. And we were an integral part of the medical board formed for the latest amendment of the MTP Act. So this is a very proud moment for the SNS that we are the part of this Amendment Act. Now coming to the preventive oncology. As we all know, that cervical cancer is still prevailing in our country and is one of the major preventable cause of the death of the female population. We are working towards creating awareness in the general public and are training the doctors for the same. And till date, we have trained almost 318 doctors and 20 nurses so far. And Dr. Mohan Meena is putting so much hard work for this training. This is a colposcopy room. The future prospects, dreams, sapne. सपने हमें हमारे को सपना देखना अच्छा ही लगता है, सबको अच्छा लगता है, और सपने देखने में हमारा कोई सानी नहीं है। हमारा पहला सपना है टू रिड्यूस द मैटरनल डेथ सिग्निफिकेंटली। हम ये सोचते हैं कि आज भी हम जो है एक विकसित श्रेणी के देशों में आते हैं, क्यों नहीं, हम बिल्कुल विकास डेवलप्ड कंट्रीज में। सो दिस मैटरनल डेथ एंड पेरिनेटल डेथ, दीज आर द वाइटल स्टैटिस्टिक्स। तो हमारा काम इस मैटरनल डेथ को हम बहुत कम करना चाहते हैं। जो आज़ादी के समय ये 1000 थी, आज हम इसको 100 के करीब ले आए हैं। तो मैं ये कहना चाहती हूँ, और ऐसा हुआ क्यों? मैं कहती हूँ ये कम हम इसलिए कर पाए कि आप सबका मेडिसिन डिपार्टमेंट, एनेस्थीसिया, ब्लड ट्रांसफ्यूजन, माइक्रोबायोलॉजी, इन सबका, सर्जरी, सबका योगदान है। और ये एक तरह से एक टीम वर्क था जो कि हम इस मैटरनल डेथ को इतना कम कर पाए। और मैं उम्मीद करती हूँ क्यों हम 100 पे ही रहें, क्यों ना हम भी विकसित देशों की तरह 30-35 पे उतर के आ जाए, क्यों ना हम 5-7-8 पे उतर के आ जाए स्वीडन और डेनमार्क की तरह। ये हमारा ड्रीम है सर। तो हम आप सबका सहयोग चाहते हैं, खास करके मेडिसिन का। एनेस्थीसिया का तो हमें थ्रू आउट 24 घंटे मिलता ही रहता है, पर मेडिसिन का बहुत अच्छा सपोर्ट चाहते हैं सर। फीटल मेडिसिन, हमारा डिपार्टमेंट इसके लिए बहुत वर्षों से प्रयासरत है, और मैं सोचती हूँ बगरट्टा साहब इस पे बहुत ध्यान देंगे, ऐसा मेरी उम्मीद करती हूँ सर। इसको प्लीज सर इसको चालू कराएं। और क्यों फीटल मेडिसिन अकेला, क्यों ना फीटल सर्जरी भी जब दुनिया करती है, हम क्यों नहीं कर सकते? हम क्यों पीछे रह रहे हैं? हम भी करना चाहते हैं, इसरो को रोबोटिक्स भी करना चाहते हैं, हम यूट्राइन ट्रांसप्लांट भी, ये हमारे ड्रीम्स हैं। और हम जो है ये सपने जो हैं, हमें अब्दुल कलाम साहब याद आते हैं कि जो कहते थे कि सपने कौन से होते हैं, वो होते हैं जो कि हमें सोने नहीं देते। सर हमें ये नहीं सोने देते हैं, प्लीज सर इनको करवाइए यूट्राइन ट्रांसप्लांट। हमारा देश पायनियर है, पूना के डॉक्टर ने 3 यूट्रस ट्रांसप्लांट किए हैं, महात्मा गांधी भी करने जा रहा है, तो हम भी चाहते हैं हम भी करें सर, इसमें काम करें सर। थैंक यू वेरी मच, थैंक यू वेरी मच सर।
Thank you so much, ma'am. That was a very quick brief about the department. Now I would like to invite our beloved principal, sir, Dr. Rajeev Bagarhatta, sir, to address the gathering. He has been the nudging force behind this CPC. So please welcome on the stage.
Good afternoon, everybody. First of all, at the outset, I would like to apologize for keeping you waiting and for the delay in start of the CPC today. I was involved in one of the cases. The case was sick, but luckily before I came, the case was done. So at the outset, I'm really sorry. In fact, I did not want to miss even a single moment of today's CPC, because this CPC is giving me a chance to revisit that department under which I was trained, I think 30 or 35 years ago. Those days of spending nights together in the labor room and the excitement there, and juggling with the female pelvis, trying to take out the deliveries and the dummy. And most of the time we were fumbling. So with those loving teachers, endearing teachers, and the seniors too. So I did not want to miss a single moment today. And but I'm sure that I don't miss much with Madam's presentation of the department. It was so very inspiring, and also I found her presentation today to be all inclusive and to be futuristic also. I'm part of the program, ma'am, and I'll leave no stone unturned to see your dreams through. Having said that, I would like to share an experience which is only 1 week old. I happened to be in Jaipur, where all the cardiology alumni from PGI had gathered together, and I was part of it. One of the ex-PGI directors, Professor K.K. Talwar, who is also a cardiologist, he was present there. And when he was enumerating the strengths of PGI Chandigarh, the first line on that slide was the CPC at PGI. And so many orators came, so many discussion came. They said that PGI is not only training of postgraduates, it's also the training of the people who are trained there to go to different parts of the country. and bring up an atmosphere of what PGI is all about. I was the lucky one, the only one, in fact, to go up and stand there and tell them that I am trying to implement what PGI is all about. And CPC is one of the most important landmark of our institution. I thank the Department of MEU, the convener of the team CPC under the convenership of Dr. Puneet Saxena, for having seen this dream true, which is a very important part of our academic program. I think I can request the departments who are dealing with the surgery that they can come up with the CPC in which the biopsy plays a very important role. CPC has got two parts. One of the CPC is like those patients where the uncommon presentation of a common case can be there, or where a common presentation of an atypical case can be there. And that's being corroborated with the pathological diagnosis. So I think surgical department can pitch in with the inputs of the biopsy diagnosis also. The other departments where biopsy is not frequently done, they can come up with very unusual cases where biopsy may be there or biopsy may not be there. These cases should have an element of relevance, some discussability, and a measure of progression of the disease course. So with these words, I am looking forward to today's CPC and to be part of this academic feast. Thank you.
Thank you, sir, for the address. Now I would like to invite Dr. Anita Simlot, ma'am, Senior Professor, Obs Gynae Department, to present the case.
Good afternoon, everybody. Before I start the presentation, I would like to inform the audience that we have taken consent from the patient and her relatives to present few pictures of her and her case and her name. The title for today's presentation is From Small Oversight to Major Catastrophe, Navigating the Ripple Effect. As the presentation will proceed, so will the title be unfolded. Now I invite Dr. Astha Jain, third year postgraduate, to present the history of this patient.
Good afternoon to one and all. Today, I'll be presenting case of Mrs. Anupam Jain, age 40 years, wife of Mr. Rajesh Jain, hailing from Agra, who came to Janana Hospital with chief complaint of irregular bleeding per vaginum since last 2 months. Let us begin our story from the beginning. It all started at SN Medical College, Agra, where the patient first presented with chief complaints of irregular bleeding per vaginum since last 20 days after the 2-month period of amenorrhea. A urine pregnancy test was advised and it was found to be negative. She was given treatment, tablet tranexamic acid, thrice daily, and high doses of progesterone in the form of norethistron thrice daily. Even on above treatment, there was no relief. So tablet or melofexine 60 mg twice weekly was added. Moving further, her bleeding increased even after above medication. So a decision to admit the patient and further evaluate was taken. An ultrasonography and NMRI was done and it showed adenomyosis. Endometrial biopsy was planned via endoaspiration, and it was during this procedure that the patient bled torrentially. The procedure was abandoned there and then, and a Bakri balloon was inserted to control the bleeding. She was transfused 4 units of packed red cells and 2 units of fresh frozen plasma. And this is an image showing the Bakri balloon inside the uterine cavity. It achieves hemostasis by its pressure tamponade effect on the uterine wall. The balloon was removed 24 hours post-procedure, and she was discharged after 6 days when her bleeding was under control on high doses of progesterone and melofexine. The histopathology report of the endometrial gland showed area of necrosis, dense acute infiltrate with no evidence of endometrial gland. Now the story takes its shift to Janana Hospital, Jaipur, where she came after not being relieved of a persistent irregular vaginal bleeding. At the time of presentation, her chief complaints were that of irregular and excessive vaginal bleeding since last 2 months. The patient bleeds almost every alternate day, even on high doses of progesterone and melofexine. Her bleeding was painless and it was associated with progressively increasing fatigability for the last 4 months. Obstetric history, she is para 3L3. Her first 2 deliveries were full-term normal vaginal delivery that took place 18 and 16 years back. Her last delivery was a full-term C-section, which was done 5 years ago for the indication of fetal distress. And it was during this pregnancy that she developed peripartum cardiomyopathy. She was admitted in cardiac ICU for 20 days. She was regularly taking medications for the above, and all her deliveries took place at Agra. Medical history, she is a known case of type 2 diabetes mellitus on tablet metformin BD for the last 3 years. For her underlying peripartum cardiomyopathy, she is taking tablet valsartan and sacubitril BD, tablet carvedilol OD, and tablet levocarnitine BD. Her family history and personal history were not significant. Upon examination, the patient was conscious, cooperative, and oriented to time, place, and person. She was obese with a BMI of 31 kg per meter square. She was pale. Her pulse rate was 90 per minute. Her respiratory rate was 18 per minute, and her blood pressure of 130 by 80 millimeters of mercury. On per-abdominal examination, there was no abnormality detected. On speculum examination, the cervix and vagina looked healthy, and there was bleeding through the os. Bimanual examination was performed, and it revealed that uterus was enlarged to up to 4 times the normal size. We further investigated the patient and found that her hemoglobin levels were 6.8 gram per deciliter. Her random blood sugar levels were 208 milligram per deciliter, and her HB1AC was 6.8%. Rest all her investigation were within normal limit. An ultrasonography was done, the findings of which will be further elaborated upon by respected Dr. Saroj, Associate Professor, Department of Radiology. Ma'am, I'd like to invite you on stage.
Good afternoon, everyone. I am Dr. Saroj, presenting the radiological aspect of this case. A 40-year-old female patient was referred to us for ultrasound with complaints of continuous vaginal bleeding since with continuous vaginal bleeding for 2 months. She gave history of 2-month amenorrhea. However, UPT was negative. So on ultrasound examination, uterus appeared bulky. Endometrium and myometrium appeared normal in region of fundus. A large heterogeneous echo-complex lesion involving anterior myometrium and endometrium was noted in lower uterine segment. Endometrial and myometrial differentiation could not be made out in this part. No definitive internal vascularity was appreciated. However, perilesional vascularity was seen. Then review of MRI film was done as already done at Agra. So MRI images shows bulky uterus with heterogeneous myometrium and poor endomyometrial junction differentiation in lower part. An ill-defined large mass seen in anterior myometrium of lower uterine segment of uterus appearing to extend up to endometrial cavity. Appearing hypointense on T1 weighted images and shows multiple hyperintense foci on T1 weighted images and T1 pre-contrast fat set images representing the hemorrhage. On T2 weighted images, lesion appears predominantly hypointense with multiple areas of hyperintensities, shows degeneration or necrosis with multiple T2 dark flow voids are seen. Multiple T2 dark flow voids are also seen along posterior and superior wall of collapsed urinary bladder. So on post-contrast images, the lesion was non-enhancing in relation to the surrounding enhancing myometrium and extending to endometrial cavity. Multiple peripheral areas of contrast pooling with layered appearance were seen. They may represent vascular channels. So on the basis of imaging findings, differential diagnosis includes leiomyoma with degeneration. They appeared predominantly hypointense with internal hyperintensity areas representing the necrosis or degeneration. However, no enhancement was seen in degeneration, but they are more well defined. Next is the adenomyosis with focal adenomyoma. They appeared hypointense on T2 weighted images with internal hyperintense areas. They are ill-defined borders and have poor endomyometrial junction differentiation, but they shows intralesional vascularity and they are more common in posterior wall with no mass effect and the normal uterine fundus and posterior endomyometrial junction. Next is the chronic RPOCs, as the location was anterior myometrium of lower uterine segment at or near the scar site, extending to endometrium, and multiple vascular channels and non-enhancing components which represent the hemorrhage or degeneration, but there was no clinical history of recent pregnancy, MTP or abortion. So neoplastic lesions were not considered as the lesion did not show any enhancement on post-contrast MRI. Thank you.
Good afternoon, everyone. I'm here to take the story further. Next. On the basis of our clinical examination, our history, and help from our radiology department, we made a provisional diagnosis of abnormal uterine bleeding due to adenomyosis and leiomyoma, also known as fibroid. As the patient's condition was a bit difficult, so we planned a hysterectomy straight away in view of past history of torrential bleeding on endoaspiration, a non-responsive uterus to medical management, and falling levels of hemoglobin. Hemostats and high dose of progesterone were continued meanwhile. Packed red blood cells were also transfused, and various references were sought in view of underlying comorbidities. First of all, we sent the patient for a physician reference, and they advised us to correct the anemia and to initiate insulin, both regular and glargine, and they categorized the patient as a very high-risk case due to obesity and type 2 diabetes and advised cardiology clearance. We also sought endocrinology reference and insulin was started, both regular at the dose of 4 international units 8 hourly and glargine at 6 units at night. Blood sugar was monitored and insulin dose was adjusted accordingly. So, as the condition of the heart of the patient demanded a heart-to-heart talk with the cardiologist, so we sent her to the Department of Cardiology. I now invite Dr. Bhaswati Pathak to explain the condition of that patient at that time.
Thank you, ma'am. Cardiology reference was taken for the patient seeking cardiological clearance before hysterectomy. On examination, she was a known case of peripartum cardiomyopathy and she was on guideline-directed medical therapy for the same. On examination, her vitals were stable. The significant finding was that she had anemia. So severe pallor was present, severe anemia was there. And on systemic examination, serious examination, there was the positive finding was that there was cardiomegaly. The apical impulse was felt in the fifth intercostal space, 10 centimeter from the mid-sternal line, and it was diffuse. ECG showed the sinus tachycardia and the poor RV progression, signifying there was DCMP, underlying DCMPs. 2D echo was done in September 2018 when she was diagnosed with peripartum cardiomyopathy 6 years back. At that time, the echo showed concentric LVH, mild MR, moderate TR, moderate LV systolic dysfunction, EF of 35 to 40%. IVC was normal, more than 50% collapsibility was there. At our center, repeat echo was advised for the patient in June 2023, and it showed global hypokinesia of the left ventricle. LV was enlarged with grade 3 left ventricular diastolic dysfunction. mild MR, mild TR. Severe LV systolic dysfunction was present with an EF of 30%. There was persistent dysfunction of the systolic dysfunction of the LV all throughout these years. Pro-BNP, we advised pro-BNP for the patient, anti-pro-BNP, and it came out to be 702 picogram per ml. So we came with a diagnosis of dilated cardiomyopathy with severe anemia as a result of follow-up case of peripartum cardiomyopathy with persistent LV dysfunction or no recovery, with no signs of heart failure, and she was without any cardiogenic shock. We advised the patient to continue her guideline-directed medical therapy for heart failure. Cardiological clearance was given according to the revised cardiological risk index, and she fell under the moderate risk category. On-table, we also advised her on-table vitals and ECG monitoring to look out for arrhythmias and possible shock. Diuretics was advised, and we also advised caution regarding the fluid therapy intraoperatively. Blood transfusion was advised to correct her hemoglobin levels, and the dietary restriction of salt and water was also advised for the patient. We anticipated certain dangers for the patient, like she might land into heart failure or cardiogenic shock, as she was having pervaginal bleeding at that time, and she was already a known case of heart failure. Arrhythmias and thromboembolism were also anticipated in this patient, and also sudden cardiac death due to some dangerous arrhythmias like VT. Thank you.
Thank you. So after obtaining all the references, we sent the patient to Department of Anesthesiology for a pre-anesthetic evaluation with repeat investigations. Her investigations on the day of PAC, hemoglobin was 7.4 gram per deciliter, random blood sugar was 198, HbA1c was 6.8, and chest X-ray showed cardiomegaly. The CNS, respiratory and airway examination done by the Department of Anesthesiology showed no abnormality. But now, as she was a high-risk case, we decided to post her as an elective case in a routine OT under senior Obs and Gynae faculty, senior anesthesiologist, and if required, the presence of physician and cardiologist. But, things are not that simple. The uterus was quite obdurate and it had different ideas. One fine day, before we could post the patient, she started bleeding profusely and took all of us on a roller coaster ride. As the patient decided bled profusely, we took her for an emergency hysterectomy on 12th June. On opening the abdomen, we found that the uterus was grossly enlarged. It was enlarged up to 4 times its normal size with multiple adhesions. The adhesions were on the left side, and uterus and the adnexa was found adherent to the gut. These adhesions were separated. The isthmus, or the lower part of the uterus, was quite enlarged. It was around 10 to 12 centimeter, necrosed, friable, and showed increased vascularity. This necrosed part of the isthmus was also infiltrating the posterior surface of the urinary bladder. The bladder was adherent to the isthmus and it was also uplifted. But hysterectomy was proceeded and it was done, and the vaginal stump was closed at a clear margin. When we were suspecting a bladder injury, and we did a methylene blue dye test, and we found out that a 1 into 1 centimeter bladder injury was there on the posterior surface of the bladder. This is the specimen that was sent to the Department of Pathology for HPR. And when there was a bladder injury detected, we remembered our 2 friends, the urologist, the dynamic and intelligent team of urologists came to our help. And I invite Dr. Sumendra Bansal to explain how skillfully he managed this case.
A very good afternoon to all of you. In continuation of this CPC program, we received the call from the gynec department, and in intraoperative finding were 1 into 1 centimeter rent in the posterior wall of the bladder with adherent residual uterine mass in the posterior surface of the bladder with diffuse oozing. So we planned for the anticystostomy. Bladder was open anteriorly, and check the extension of the lesion to the up to the mucosa. But mucosa was normal. Bilateral uretic orifice were cannulated with the uretic catheter to check the patency of the ureter. Ureter were normal, and there were clear reflux from the ureter. So there were no uretic injury. So we planned for closure of the cystostomy. Cystostomy was closed in the 2 layer. First layer is continuous observable suture, and another layer with interrupted continuous interrupted observable suture. And we put the SPC from the separate side and close the entry wall of the bladder also in the 2 layers. We check the leakage of the urine by filling the bladder with the SPC. Around the 200 ml of the saline was put in the bladder, but there were no leakage. And we put the omentum between the repair of the posterior bladder wall and the vaginal stump to prevent the chances of the vesicovaginal fistula. And post-operative period was uneventful. We kept the SPC and Foley catheter for 3 weeks. And anticholinergic medicine solifenacin is given to prevent the bladder spasm, so there is no chance of the leak. Thank you.
Thank you, Dr. Bansal. Surgery completed successfully and the anesthetist played a vital role. I would like to speak for them. सर्जन्स को शोहरत का शौक है मगर मुमकिन नहीं एनेस्थीसियोलॉजिस्ट से रिश्ता जोड़े बगैर. I now invite Dr. Komal Singh to speak about the anesthetic management of the patient.
Thank you, ma'am. Good afternoon to one and all. We received a patient for emergency hysterectomy who was not fasting, which posed a challenge for us. The high-risk consent was taken for incomplete fasting and associated comorbidities. ASA grade 4 was assigned to the patient. Pre-medication in view of incomplete fasting was given. Injection Rantec, injection Reglan was given. Injection Midazolam and injection Glycopyrrate were also given. Injection Fentanyl to assure thorough analgesia was given. Pre-oxygenated with 100% oxygen for 3 minutes. Induction with a cardiostable agent etomidate was done. Injection succinyl choline was given after assuring proper bag and mask ventilation. Under DL, the patient was intubated by using a special technique that is rapid sequence induction, which we use for incomplete fasting. Maintenance was done via atracurium and oxygen and sevoflurane. Intraoperative vitals were monitored. When surgery started, we observed a drop in BP of 80 to 45 mm of Hg, for which NOR-AD was started, that is noradrenaline was started at 30 microdrops per minute. Intraoperative blood glucose was maintained by a neutralizing drip, that is 8 units of regular insulin and 5% dextrose, and monitoring was done accordingly. Intraoperative arrhythmias were observed, for which injection lignocaine 2% 3 ml diluted was given. For same, cardiologist opinion was taken. Intraoperative fluids were given. Proper analgesia was maintained by injection fentanyl and injection paracetamol. After completion of surgery, all the anesthetic agents were withdrawn. Injection ondansetron was given. Patient was reversed. Post-operative vitals were as follows. Post-operative advice was given for continuing with humidified oxygen support via non-rebreathing mask at 15 liters per minute. Vital monitoring was advised. Input and output charting were done, and blood sugar charting was also advised. Cardiologist opinion was sought for the same. Thank you.
Has the post-operative condition of the patient demanded her to be shifted to the medical ICU? We thought of our friends, the physicians who are a ray of sunshine in any moment of darkness that we encounter. I now invite Dr. Madhulata Agarwal to share the patient's journey further and her stay at medical ICU.
So the journey of the patient further, she came to us in the ICU in state of dyspnea, NYHA grade 4 with hyperglycemia, uncontrolled sugars. Patient was morbidly obese, known case of diabetes since 6 years, and peripartum cardiomyopathy since 5 years on treatment. Patient was highly dyspneic and was on high flow mask at 15 liters of oxygen. She had a normal GCS. Her vitals, she was in tachycardia. She had a blood pressure of 116/70 on minimal nodded support, 1 ml per hour. And as I told you, she was dyspneic. So general examination, patient was morbidly obese. She had a poor general condition. She was pale, and systemic examination showed a left ventricular S3 in cardiovascular examination. Respiratory system showed she had bilateral fine creps with occasional V's, indicating she was in left ventricular failure. So investigations were sent and they came back as she was anemic, hemoglobin of 6.9. She had elevated counts, 16,000 with 85% neutrophils. She had increased sugars, 260 milligram per deciliter. Her renal functions were deranged with increased creatinine of 1.7. She also had hyponatremia, hyperkalemia. She had serum lactate levels of 2.2. Pro-BNP was elevated again, favoring failure. And there was a D-dimer 1790 with procalcitonin of 5.7, leading us to suspect that she was also in sepsis at the time of presentation. ECG showed sinus tachycardia. X-ray had cardiomegaly with back pain appearance. Echo, which was done on the same day, showed that she had a global hypokinesia of LV, as she was a case of peripartum cardiomyopathy with a poor LV systolic function and ejection fraction of 30%. So she was diagnosed with us as diabetes, morbidly obese, peripartum cardiomyopathy, who presented to us with left ventricular failure, with severe anemia, sepsis with AKI, and hyperglycemia. Accordingly, we started antibiotic therapy. We started her on injection meropenem, which was given as an hourly infusion, metrogyl. And then she was given supportive care with oxygen by high flow mask, diuretics for failure, minimal vasopressor support, nutritional build-up, recumbency care, 2 units of PRBC were transfused, and she was put on Vimara, and that is sacubitril plus valsartan along with carvedilol as advised before, and as opinion was taken from cardiologist. Hyperglycemia was initially treated with low-dose insulin infusion for the first 3 days, and once she started taking orally, patient was shifted on a basal bolus regimen. She also cardiology, nephrology, and urology opinions were sought accordingly, and patient was managed conservatively. She gradually improved over the next few days with counts getting normalized. PCT showed a decline. There was improvement in acute kidney injury, and the failure part improved. She was hemodynamically stable, and she was transferred back to Janana Hospital on post-operative day 6.
All the doctors were wondering, what was she actually suffering from? Was it a gene-related fibroid? Was it adenomyosis? Or was it malignancy? There's a famous novel, a sensational medical novel by Arthur Helle, The Final Diagnosis. In this, the climax is very interesting, and so is the climax of our case. And a twist was brought in our story. And as you all must have guessed by now, who has brought the twist in our story? The Department of Pathology. I invite Dr. Suman Kotia to please speak on the HPR of the patient.
Before the final diagnosis, open for discussion.
Okay, sorry. Acha, before this?
Yeah, before the final CPC actually has
If you want for the opinion from the audience that what can be the diagnosis.
Oh, good. That's good. Okay, so what is the final diagnosis as per the audience? Probable.
Many people from the Obs and Gynae department
They know
the
about it.
diagnosis.
So please, no, Ramesh, not you. Okay. Yes, Leela Didi. You don't know about the final diagnosis.
Most probably looking towards a history.
Yes.
Of these things. It may be a scar side pregnancy.
Yes.
Which is very common nowadays.
Is there a history of, was there a history?
It's not present. Actually, only the UPT has been done.
Yeah.
So initially, because in Agra, they have done that they have patient came with the
The UPT was negative there.
UPT, only the UPT.
Yeah.
They have not gone for the passage and any level. And a patient bleeding, not responding to norepinephrine, जिसको कि हम लोग रामबाण दवा बोलते हैं. Norepinephrine is for us, and we are expanding to the estrogen.
Yes.
So one thing is that. Another most important thing, once any lady is coming with such a bleeding, next time you are taking, you should have the sono guided procedures, which is mandatory. And everywhere in the medical college, we are letting with the sonography in the ORs. That is required, and Dr. Bagarhatta, again the request from you to give them.
Actually, yeah, Leela Didi, actually the endometrial biopsy was taken at Agra and it started bleeding profusely. So we did, okay, you are telling about them, for them, okay.
I'm saying they are not.
Yeah, okay, right.
This is not available there.
Yeah.
So this is not there. So if any mass has been detected at that time, a mass which is at the scar site and which is invading towards the bladder, it directly give you a clue that it may be some scar side pregnancy, which is usually neglected. It's not undiagnosed, but she has not gone to anywhere. And there are, if you find out the other story, she may have the amenorrhea of few days and gone. Then she must be having the started bleeding. She thinks, oh, no, there is no bleeding. She must have done UPT there or not. That's
Beta HCG was done here.
Beta HCG
Was done here.
Beta HCG was done because she came to us around 20 to 25 days after getting discharged from Agra.
But
So
still-
serum beta HCG was done and it was not raised.
Yes. So it is if the chorionic tissue, we know it. Chorionic tissue get degenerated. So the first diagnosis looking towards in recent scenario, which is all the, not only the pregnancy, it is all the scar side complications, which is a big topic which we are all sonologists, all endoscopists, definitely the basic gynae and all, they know it. And we are going with this thing and always, same way within the placenta. So once there is a pregnancy, I think the sonologists all are good. Anu, you are there. We always see the first, if any of the previous scarred pregnancy coming, it's not only कि देख दो G-sac है कि नहीं है. So we always say the site of G-sac, whether it is in the upper part or in the lower part. Even if it is in the lower part, we see for the scar site. If it is, you find in the scar site, in the inner side, or it is in the mid or in the outer side, it is going down. So these are all precautions we are taking, and all history, all the clinical examination till date. I think my first diagnosis would be it may be a scar site pregnancy which has been neglected, and gradually the bleeding started and hematoma formation.
Yes, ma'am. But the problem is that our sonologist.
Another thing is that whether you are doing in the emergency or anything which is going towards bladder, urologist friends should be called immediately before starting something.
Thank you.
Shall we proceed?
Madam, in this case, the imaging was done, so the chances of the gestation sac is ruled out.
Yes, so that's what I wanted to say.
There was no fetus in the uterus.
So just, there is no chance of a gestation.
And I would like to add one more thing. Ma'am, the sonologist here, they saw the patient, if at all it was a pregnancy, they saw the patient after a considerable amount of time. They did not see any problem at the scar or any fetus or any remnants. So that was a very big difficulty or challenge for them to label it as a scar site or even chronic RBOCs. It is always a possibility, but
Terminology has been given
Yes.
nowadays. It is the scar side complications.
fine. I agree. Definitely, I agree.
Okay. But there was no fetus. Oh, sorry.
So one is when you're taking the history of the patient, we probably missed the past history which should have been taken.
No,
properly.
excuse
The
me.
cesarean section, which was done 5 years back, what was the intraoperative finding? Was there any problem related with the cesarean section? What type of pregnancy? What type of placenta? Whatever it is. So a proper history should have been taken at that time. Secondly, when we are doing imaging, I would like to ask the radiologist, when we are doing MRI, so should we also have done the diffusion coefficient, diffusion restriction, and a chemical shift MRI, which can tell you a lot many things when you do MRI. So that again is very important. And thirdly, when you made the diagnosis of leiomyoma or adenomyosis. So adenomyosis we know is the endometriosis of the uterus, right? So usually it will have a chronic pelvic pain as a part of the chronic pelvic pain syndrome. So did she have that kind of a pain to make you a diagnosis of adenomyosis? And if you make the diagnosis of leiomyoma, so does the leiomyoma bleed like that, the way that she bled? So why did you make the differential diagnosis of
Sir,
Yeah, he
both
wants
of
to say something.
So I want to add something.
Yeah, please.
So since this patient landed in our unit, so actually the attendants were also, they were right because the first possibility which we kept was malignancy.
Yes.
Because she was bleeding profusely, the uterus was enlarged, the biopsy was not available. And they did hysterectomy, and we were thinking that she is having endometrium being 40 years of age, and somehow the patient improved. And the suspense came after only the histopathology which we received when the patient was with us only. So that was the catch, and fortunately the patient recovered and then was subsequently shifted back to that. So that's the story unfold, and probably then we can have.
One more thing which I think is important is that are we able to explain everything by one diagnosis? the patient also has cardiomyopathy.
Yes.
So is that related to your diagnosis, whichever is unfolding now? That would be interesting, or it's just unrelated?
It's unrelated. Cardiomyopathy is unrelated. Only it made the patient a very, very high risk case. We were very afraid. And as far as the history was taken, it was taken in a very good way. We always ask them leading questions. That is what, only for the history part I'm telling you. We always ask the patient as leading questions about her deliveries, about her number of abortions she has undertaken. That's another point. And regarding the the diagnosis, whether it's fibroid or whether it's adenomyosis or whatever it is, that was based on the sonological.
All I think I was asking was
Okay.
the cesarean section history was
Yes,
taken.
sir. Yes, we take.
Secondly, if the symptoms were not for the last 5 years, the cesarean was done 5 years back.
Yeah, no symptoms. No
And the symptoms appeared much later.
Much later.
So her diagnosis of a scar-related complication, probably why should this occur after 3 years? Pregnancy is ruled out. Pregnancy is ruled out with the image.
When will she develop the cardiac symptoms?
Ma'am, last 5 years. She had peripartum cardiomyopathy after the last.
Delta was saying, if it has something to do with her diagnosis, then it would be peripartum cardiomyopathy, or it was some other cardiomyopathy. That's what he was trying to say.
Yes, so she has peripartum cardiomyopathy which developed in last.
One thing that the past history of any abortions or DNC.
Yes, ma'am. She did not give any past history of any abortion, any medical abortion, any DNC for any other reason also, for any gynae.
Was a Doppler performed along with the ultrasound?
Yes, Doppler.
Vascularity, yes. No. On ultrasound was hemorrhage. What was the report of biopsy of Agra?
Yes, sir. The Agra biopsy report was quite inconclusive. It was shown.
Areas of hemorrhage.
It only showed areas of hemorrhage and necrosis. And they also reported that they could not see any endometrial glands. And probably they did not curate it properly because the patient started bleeding profusely. So,
Could we have done a review of the biopsy? Could we have done a review of the biopsy?
No, because there was already a complication there. She bled so profusely that we could not do it again. They had to review. Okay, she didn't bring the biopsy along with her tissue.
We could have asked. Because if you're thinking in those terms, then we could have asked. Because we were planning for a surgery. And we could have been a malignancy also. So whenever such things is planned, then we should ask.
Yeah, because actually she was admitted here only for 4 days and she had come from Agra. So getting a report from that would have taken time. And while we were preparing, this mishap occurred and we had to do it as an emergency hysterectomy. We couldn't do it as a plan. That was the problem.
So, Madam, let's proceed now.
Okay, sorry. Okay, Dr. Suman, please. Yeah, this makes it interesting.
Thank you, ma'am. Myself, Dr. Suman Kotia from Department of Pathology. So, with the requisition form and the clinical history, we received the specimen of bulky uterus with bilateral adnexa that is measuring 14 by 9 by 7, along with a separate cervical tissue that is 6 by 5 by 3. On further sectioning the specimen, the cervical lip was appeared normal, cut surface was unremarkable. Endometrial cavity was patent, dilated and filled with the blood clot. And endomyo thickness was 2 cm. And a single tiny intramural fiber was identified that is only 0.3 cm. And both the adnexas appears unremarkable. So next we come to the microscopic examination. So when we see under the microscope, here you can see, when you see under the microscope, in the first photograph you can see these structures and we amazed to see these structures in the uterine wall reaching up to the serosa in the background of hemorrhage and necrosis. As you can see, that is the upper side is a serosal surface.
Arrow use करना, pointer तो
So in this photograph, as we can see these structures, these are present in throughout the uterine wall, reaching up to this serosal surface in the background of hemorrhage and necrosis. Also, you can see in this photograph. So, we are amazed to see these structures. And these are what? These are the chorionic villi. As you can see in this picture, this is the serosal surface, and these are the chorionic villi lined by the trophoblastic cells. And this is the hemorrhage and the inflammatory cells. Also, you can see in this structure.
I'll show you. बहुत fine है. लो, पर मुझे पता नहीं है कहाँ करना है. You press it hard. No, press it hard. हाँ, नीचे से उंगली हटाओ.
हाँ, अब है ठीक. So these are the atrophic coronary villi. Yeah, as we can see in this photograph also, these are the chorionic villi lined by the trophoblastic cells, and this is the serosal surface. So there is no intervening myometal fibers. So it reaches up to the serosa throughout the wall, and there is no intervening myometal fiber, and then there is no decidua here. So in the next photograph, also in this photograph, you can see these are the atrophic villi, and this is a calcified villi surrounded by the dense inflammatory infiltrate. These are the syncytial, multinucleated syncytial trophoblastic cells in the myometrium, and these are also the chorionic villi lined by the single layer of cytotrophoblastic cells, decidual cells. And in this photograph, you can see the blood vessel that is surrounded by the decidual cells undergoing fibrinoid necrosis. And these are the changes of normal placentation site where a blood vessel is converted into a dilated sac. So at this point of time, we ask the patient, we call the patient for the relevant history. We ask her reading questions about her recent conception, but she refuses blindly and she did not give any history. So however, we give our final diagnosis, that is what is the placenta percreta. So our final diagnosis is the placenta percreta. So on the basis of clinical history and the microscopic finding, our diagnosis is a placenta percreta. So this is all from the pathology department. Thank you. Yes.
How would you differentiate it from choriocarcinoma?
Choriocarcinoma. Sorry, here we can see the normal villi lined by the single layer of cytotrophoblasts and syncytial trophoblasts. There is no bizarre cells, there is no atypical cells, hyperchromatic cells. There is no feature of malignancy here. There is no mass grossly also invisible. So we can. Yes, ma'am. Yes, sir. Yes, sir. It is your. Thank you.
Summarize. We are already.
Okay.
Excuse me, ma'am. So, sir,
एक minute, just a minute.
Chorionic villi in choriocarcinoma. This is a very much a picture of a normal placentation site where we are seeing normal.
Let us
villi
complete.
with a blood vessel undergoing the normal placental changes. So we rule out choriocarcinoma.
Yes. Now, once we told the patient about the report, a histopathological report, and again we asked her if she has ever undergone abortion. Even to the surprise of her husband, she admitted, yes, I have taken medical abortion pill over the counter. This is the thing, but no one from her family knew, not even her husband. When we told her the report, then she admitted. So, what these medical abortion drugs, they come under MTP Act. And only registered doctors can prescribe it, and the medical shops cannot give it without prescription. Giving it, it is considered illegal. And hiding this important fact put her life in danger. As Benjamin Franklin has slightly said, don't misinform your doctor nor your lawyer. I'm just summarizing, I'm just ending, don't worry. Now we had answers to some unexplained events. Now, why was the bleeding not under control with high doses of progesterone? Because it works only on the endometrium. Why was there torrential bleeding during endoaspiration in Agra Medical College? Because invading the placental tissue is highly vascular and the cannula must have entered into that placental tissue. Lastly, why was the isthmus friable and invading the urinary bladder? Because it was a case of placenta percreta. Patient has been discharged and she has conveyed her thanks to the SMS college, medical college, all who cared for her, and discussion. Make it short.
Sir, placenta equita spectrum is abnormal adherence of the placenta and which invades the myometrium during pregnancy. As evidenced by this video, if the placenta, if there is a defective decidualization, the placenta tends to invade the myometrium and it might come up to the serosa and might invade the surrounding structure, that is the urinary bladder in most cases. And there is an increased vascularity at this area, making the situation difficult. And this is termed as placenta perquita. The risk factors include previous cesarean sections, placenta previa, and if there is a combination of two, the risk increases exponentially. Other risk factors are advanced maternal age, multiparity, Asherman syndrome. Patient lands in a lot of number of complications, important being massive peripartum hemorrhage, leading to peripartum hysterectomy, urological injuries, and even mortalities. Now, why have we presented this case? This is one of the last slides. The presence of adherent placenta for 3 months after the fetus was expelled is a rarity. Negative urine pregnancy test and no evidence of the fetus in the uterus made the diagnosis difficult for the sonologists also. Detection and complications caused by morbidly adherent placenta in the first trimester are usually rare. A systematic review has suggested only 23 cases of placenta equita spectrum in the first trimester abortions, further explaining the rarity of this case. And finally, last but not the least, a prompt and dedicated multidisciplinary team work from SMS Medical College was able to save this patient.
So the take-home message is medical abortion drugs can sometimes lead to life-threatening conditions. Hence, their sale should be monitored strictly. Number 2, placenta accreta spectrum should be diagnosed as early in pregnancy as possible. Number 3, if a woman with irregular bleeding per vagina comes to you in the reproductive age group, rule out pregnancy. So let me at the end describe the title given. What was a small oversight? Hiding history of abortion. And what was a catastrophe? Emergency hysterectomy as a very high risk case. She barely survived. Ripple effect. What was the ripple effect? All the intraoperative and post-operative complications which happened. Our sincere thanks to the Department of Internal Medicine, Urology, Nephrology, Pathology, Anesthesiology, Cardiology, Radiology, Endocrinology, and Mrs. Anupam and her family. Thank you.
And so the brainstorming is still continued. I'm here to give a quick vote of thanks. My role is always very small, but it is important to show my gratitude to the entire CPC team, to our principal and controller for giving this academic feast a start. We are on to the 7th CPC. Wishing all of you a very colorful, happy and prosperous Holi. And my sincere congratulations to the Department of Obs and Gynae and Anita ma'am for the excellent CPC intake with all parallel department, nephrology, urology, radiology, pathology. If I'm missing anything, then whole of the department anesthesiology. And important thing is, what I want to say is today, cardiology, yes, how can I forget that? I'm so sorry. And nephrology I've mentioned, sir. The important thing which I want to announce is today is a very unique day. It is not only a CPC day, we can see a platinum stars sitting here and also the former head of the departments and the faculty of Obs and Gynae. And a secret to share that today is birthday of Dr. Pushpa Nagar madam, and probably she'll be retiring in March, and I have brought a bouquet. So I will request all the Obs and Gynae faculty, the former and the present, and principal sir and convener CPC team to please give a floral happy birthday wish to ma'am. So can we have the, happy birthday ma'am. Wish you a very happy birthday. Thank you all for attending the CPC.